Speaking of combinations, there's some early data, even before PD-1, PD-L1, looking at ipilimumab, so CTLA-4 inhibition. Comments, Everett, about that, and whether you think we'll see a day where we'll be combining agents like ipilimumab with nivolumab or perhaps the PD-L1
I think that could well happen, Corey. Ipilimumab came along much sooner, so it's been around a bit longer. It's approved in treatment of melanoma. And in non-small cell lung cancer, there was a non-definitive but very interesting randomized phase 2 study that was eventually published by Tom Lynch. And it compared a standard, I think, carbotaxol chemotherapy arm versus the addition of ipilimumab either right away or after 2 cycles. So it was, I think, referred to as concurrent versus sequential. It was the sequential arm that showed the best difference favoring progression-free survival for ipilimumab. So arguably the first proof of principle that immune therapies mattered in non-small cell lung cancer, because as you well know, all the prior attacks or trying to awake the immune system or get it involved had not worked out, but this one did work. And ipilimumab is now in more definitive clinical trials, so we don't know the answer yet. Could it affect survival? But while this is ongoing, there is early phase work going on in a multiplex randomized phase 2 or phase 1 trial. As I understand it, and one of those arms combines ipilimumab with PD-1 inhibition and tries to look at the two together and make sure that we understand how they should be given and get some early signals for activity.
Certainly that looked very exciting in melanoma at this year's ASCO. We've talked about this agent as if it has no toxicity. Anne, comments?
No, this is a totally different realm.
Therapy.
Yeah, this is not benign. So most of these immunotherapy agents are going to be giving you rash, diarrhea, nausea, headache, pruritus. But perhaps more concerning is that you can get serious adverse events like hepatitis, colitis, fatal pneumonitis has been reported. I mean, these are typical autoimmune reactions because when you mess with the immune system, that's a potential toxicity that you have to encounter. So usually, management of these side effects is something that requires a lot of vigilance for the patients. You got to get them on steroids very quickly and try to calm down the immune system.
Is crucial.
Very critical.
Roy, some of the early data, certainly with ipilimumab, suggested that there was a preferential benefit in squamous cell histology. In fact, the phase 3 trial is confined to patients with advanced squamous cell. And I think, again, some of the early work with PD-1 with nivolumab suggested a preferential benefit in squamous. Is that still panning out or not?
I don't think that's true. I actually think the nivolumab, there are 2 trials ongoing right now, both versus docetaxel, one in squamous cell and one in non-squamous cell. And you know as well as I, Corey, just looking at response rates, it's hard to say much. My sense is, and we've treated a large number of these patients at Yale, is that response is seen in both tumor types. The other thing I want to just add to Anne, well, you can have some very unique toxicities here. And of course, early on, before many became used to how to deal with these toxicities, there were some episodes of pneumonitis, which are especially concerning in our population where they might have had surgery or radiation. And you do see patients with some immune-related toxicities where you might have to work with an endocrinologist a little bit more than we normally would. I've actually been impressed by how safe these are and how well tolerated these agents are. And then, of course, patients can go for a year or 2 years, and then you stop the drug, and then they continue to do well. So I think at least using these agents alone, now if you combine it with ipilimumab, that might be a different story. I think that we do have an agent that's going to become a backbone now for combination with some of the other targeted therapies that we use. And I'm very intrigued by the whole fact that every patient I've ever treated with gefitinib or erlotinib, and I've done a lot over the years, always has recurred. And wouldn't it be great if we could think about combining an immune therapy with one of these agents? I think it's going to be a perfect match. So there's so many possibilities here.
So that's absolutely true. I don't think we've actually cured anybody with a molecular targeted agent, at least not yet. Karen, this class of agents, how do you think you would, if you controlled the golden pot of money, how would you develop it further? What kind of clinical trials do you think would be ideal?
Well, I think, I mean, obviously they're moving forward kind of in the second line area and as single agent, but I think probably where we're going to see more efficacy is with combinations and
So
again,
potentially up front with a platinum-based combination.
potentially, or with combinations with targeted therapies. And I think that, again, harnessing the immune system is not just about the tumor cell, it's about the microenvironment and what's happening there. And we know that the microenvironment promotes metastatic disease and progression, and so blocking some of those things may be attacking a part of the cancer we've been ignoring. And so I think there's a lot of potential. Obviously, the first direction is looking at it in single agent and seeing how much activity there. But I don't think I would stop if that did not pan out to be most productive.
Everett, how do you think these agents should be developed ideally?
Well, I think so far there haven't been big mistakes. They have been introduced, I think, carefully, and the right combinations are being evaluated. I'm always interested in seeing impact, and impact, of course, is cure. And the likelihood of cure gets higher as you go into earlier stages. And so what I would like to see, but that isn't where the golden pot of money usually goes, because
that's where
the
greatest
data take
potential
longer,
benefit might take.
would be stage 3, an induction or adjuvant setting.
Particularly in people who have been debulked by radiation and chemotherapy, who presumably have minimal disease burden, where you'd expect these sorts of agents to work best. Yeah, I agree with you. That's the area where I think these particular agents may ultimately hold the greatest promise.